We'll proceed to our next agenda, the opening ceremony. I will give time to the MC, Miss Siva. To Miss Siva, the time is yours.
Thank you, Miss Helda. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Waalaikumsalam
wabarakatuh.
warahmatullahi wabarakatuh.
Good day, everyone, ladies and gentlemen, distinguished guests, and beloved participants. Welcome to the International Expert Lecture, organized by the Center for Educational Development Poltekkes Kemenkes, in collaboration with the Nursing Department Poltekkes Kemenkes Tanjungkarang. It is an honor and a privilege to have you all here today as we gather to gain valuable insight from the expertise of our distinguished speakers. Before we proceed further, allow me to extend a warm welcome and greetings to our esteemed guests. Bapak Gustop Amatiria, Kemenkes, as the head of the Center for Educational Development Poltekkes Kemenkes Tanjungkarang. Bapak Tori Rihiantoro, Kemenkes, as the head of Nursing Department. Our distinguished speaker, Madam Sadiah Binti Zakaria, from Gerontology Care Expert from UCMI Malaysia, will be sharing her valuable knowledge and insight in this expert lecture. Our respected lecturers and staff, and of course to all the beloved students who have joined us here today. Allow me to introduce myself. My name is Shifa Azahra Berlianda from D3 Keperawatan Kota Bumi, and I am honored to be your master of ceremonies for today's event expert lecture. It is truly a pleasure to welcome all of you here. To officially begin this event, let us first unite our spirits and show our respect by singing Indonesia Raya. To the admin team, kindly cue the audio. Thank you. To commence our program, let us now invite Bapak Gustop Amatiria, Kemenkes, as the head of the Center for Educational Development, Poltekkes Kemenkes Tanjungkarang, to deliver the opening remarks. To Bapak Gustop Amatiria, the time is yours.
Thank you. This speaker is the kedengaran ya?
Yes, sir, you're audible.
Okay, good.
Ya, terdengar Pak.
Okay. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Honorable keynote speaker of the expert lecture from the Gerontology Care Expert UCMI Malaysia, Madam Sadiah Binti Zakaria. Selamat hadir dan selamat berkenalan Ibu. Leader of Poltekkes Kemenkes Tanjungkarang Department, the lecturer and the all student. Let us praise the MIT for giving us His endless blessing, so that we all can be here together on this specialist occasion in perfect condition and hearts. I am standing here as a representative of Poltekkes Kemenkes Tanjungkarang. I want to thank UCMI Malaysia, especially for this amazing collaboration as a following up to our MOU. This collaboration will be mutually beneficial as well as fostering a strong partnership between our institutions. The exchange of expertise and ideas is integral to advancing our academic community. I am also want to thank the speaker for giving her time to share her knowledge and expertise. Your presence or speaker from your institution and an honor for our institution and source of inspiration for our audience. To all audience, student and lecturer, I hope you can follow this event and take advantage of this opportunity to gain knowledge and discuss the topic with international experts. Lastly, I would like to thank the Education Development Center team and the Nursing Department for organizing this event. Once again, welcome to the International Expert Lecture in collaboration between Poltekkes Kemenkes Tanjungkarang and UCMI Malaysia. I also hope this event runs very well. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Warahmatullahi wabarakatuh.
Thank you to Bapak Gustop Amatiria for the inspiring opening remarks. Ladies and gentlemen, before we go to the main agenda, let's take a moment to capture these wonderful memories together. We invite all participants to join us for a group photo to commemorate this special occasion. To the admin team, kindly take some photos.
Okay, thank you, Siva. We have 12 slides here, so make sure you can turn on your camera and give your big smile. Okay, I will begin from first slide. 1, 2, 3. Second slide. 1, 2, 3. Third slide. 1, 2, 3. Fourth slide. 1, 2, 3. Okay. Fifth slide. 1, 2, 3. Sixth slide. 1, 2, 3. Seven. Okay, 1, 2, 3. I will go faster from slide 8 because there's no one turn on the camera. Okay. Okay, last. Okay, done. Thank you. Back to you again, Siva.
Thank you for Miss Helda. Ladies and gentlemen, now we move to the highlight of today's program, the expert lecture session. To ensure our session runs smoothly and effectively, it will be moderated by someone who is not only knowledgeable but also highly experienced in medical surgical nursing. He is one of the lecturers from the nursing department. Allow me to introduce our moderator, Nurse Fajar Desma Wahyudi, SKEP. Without further ado, I invite Mr. Fajar. The time is yours.
Thank you very much, Shiva. Am I audible?
Yes, Mr. Fajar.
Okay, thank you. Well, good day, ladies and gentlemen, all students, lecturers, and visitors that are from Poltekkes Kemenkes Tanjungkarang. Distinguished guests, respected lecturer, all esteemed practitioners, and all students. Welcome to our expert lecture on Alzheimer's disease. Today's session will bring us together on deeper understanding on condition that continues to challenge the health system globally, which is Alzheimer's disease. This neurodegenerative disorder not only affects memory, thinking, and behavior, but also creates a significant impact on families, caregivers, and communities. Well, for all participants currently in the Zoom, thank you for attending this Zoom. Okay, I would like to remind all of us that today's objectives that we will have deeper understanding on Alzheimer, and further we will learn from our keynote speaker regarding identification, prevention, and nursing care for patients, especially elderly with Alzheimer's disease. So we hope that this session will expand our knowledge and enrich us with our competencies in delivering nursing care for elderly with Alzheimer's disease. Based on evidence that will be delivered by the keynote speaker. Okay, ladies and gentlemen, it is my honor to introduce for all of us our keynote speaker today. Okay, she is Madam Sadiah Zakaria. She's currently work as a lecturer in University College of MAI MVP International or UCMI in Malaysia. With her academic background from Master in Nursing from UCMI as well, and she's currently registered as a state registered nurse in Malaysia. She has a teaching experience from anatomy and physiology, basic nursing, and advanced nursing covered in a wide range area and in medical surgical nursing and gerontologic nursing as well. And she also, other than a lecturer, she has an experience as a clinical nurses, as nurses in surgical ward and in intensive care unit as well. Well, with her experience, she is now an expert in gerontologic nursing, especially in Alzheimer's disease. Well, without further ado, let's welcome Mrs. Sadiah. as our keynote speaker. Ladies and gentlemen, please welcome Madam Sadiah to deliver the lecture. Mrs. Sadiah, Madam Sadiah, the floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and good afternoon. Thank you, Mr. Fajar. Okay, good afternoon to everyone. First and foremost, I would like to extend my sincere appreciation to the organizing committee, especially Mr. Sadiah. A lot communicated with me. Poltekkes, Kemenkes, Tanjungkarang, Indonesia, for inviting me to speak at the International Expert Lecture. It is truly an honor to engage with students, lecturers, researchers, and professional staff on a topic that is becoming increasingly urgent worldwide: Alzheimer disease in elderly people, prevention and care. As we all know, the world is aging rapidly. By 2050, the numbers of older people will exceed the number of children for the first time in human history. So, with aging comes a rising prevalence of chronic and degenerative diseases, including dementia. Among all types of dementia, Alzheimer disease is the most common, accounting for about 60 to 70% of cases globally. So today my vision is to bring clarity, evidence and practical insight to how we can better understand, prevent and care for individuals living with Alzheimer disease. I hope the knowledge shared will support your clinical practice, teaching roles, communication, community programs and future research. Okay, now I share my slide. Okay, nampak slide? Okay, my topic is Alzheimer disease, or we call AD, in the elderly people, prevention and care. In Malay we call Alzheimer disease is nyanyuk. I don't know in Malaysia what we call for Alzheimer disease, but in Malaysia we call nyanyuk. Okay, so nyanyuk.
Okay, we call here as Alzheimer as well.
Alzheimer disease. Okay. Okay, first, okay, before we go to the content, we go to learning outcome. At the end of the session, participant will be able to state definition of disease, epidemiology and global burdens of Alzheimer disease, explain the pathophysiology, stages, clinical manifestation and risk factor of Alzheimer disease, apply prevention and care principle in clinical and community nursing practice, to share best practice and evidence-based approach to nursing care for Alzheimer disease, and lastly, gain insight into international research and care models related to Alzheimer disease. Okay, what is Alzheimer disease? Okay, first introduction. Alzheimer disease, or AD, is a progressive neurodegenerative disorder that primarily affects memory, thinking and behavior. It is the most common cause of dementia, accounting for 60 to 70% of all dementia cases worldwide. So Alzheimer disease part of the dementia. Alzheimer disease is not a normal part of aging, but Alzheimer disease is a pathological aging. So means pathological aging is aging with disease. So Alzheimer disease is a disorder, not normal aging. Okay, definition of Alzheimer disease. Alzheimer disease is a permanent progressive neurocognitive disorder that is characterized by deficit in several dimension of cognitive functioning. Cognitive means fikiran, right? Including memory disturbance that severely interfere with the person everyday living but produce not decrease in level of consciousness. So normally patient is conscious. Okay, this one defined by Cash, Blair and Smith 2024. Okay, for immunology, prevalence and trends for Alzheimer disease, globally people aged 65 and older living with AD has increased dramatically. We estimate rising from 18.7 million in 1991 to nearly 49 millions in 2021. A 160% increase. This one from Zulf et al. 2025, Lee et al. And 2022. In the US alone, over 6.9 million people aged 65 plus are affected, projected to double by 2060. Okay, this one from Alzheimer Disease Fact and Figures 2024. So this one latest. So prevalence rises steadily with age. About 5% of those aged 65 and up to 1/3 of those aged 90 plus are affected. So prevalence increase with age. This one from Silva et al. 2019 and Dolphin et al. 2024. Okay, now we'll look at prevalence in Asia. In 2021, Asia had about 31.86 million people with Alzheimer disease and other dementia. This one for he 2025. Prevalent in Malaysia of probably dementia is people aged 60 plus is 8.5%, around 330,000 people. So many. Alzheimer disorder account for about 60 to 70% of dementia cases in Malaysia. So for dementia, 330,000 people, but Alzheimer only 60 to 70% of dementia. So this proportion, a rough estimate for Alzheimer cases in Malaysia would be 195,000 to 231,000 people. So this one I get from Ministry of Health 2024. So a recent large-scale survey 2021 found a wage dementia prevalence of 27.9% among older adults in Indonesia. So 27.9%. The result indicate could be more than 4.2 million people in Indonesia. From Farina et al. 2023. This data for Alzheimer disease prevalent beats myths. Most study report on dementia or causes rather than Alzheimer specifically. So all data I have from Alzheimer cases. Dementia cases, not specific to Alzheimer disease. So for Alzheimer's disease data is limited. So this one maybe as a gap, research gap. So we can do the research specific to Alzheimer disease data. Okay, the growing challenges of Alzheimer. What are our challenges for Alzheimer? Okay, 1.03 million deaths in Asia due to Alzheimer and other dementia in 2021. So many cases because reached 2 million. So Alzheimer disease was leading cause of dementia. Before I mentioned before, 60 to 70% of dementia from dementia cases is Alzheimer and cognitive decline in the elderly population. Okay, in projected growth, 2 times dementia cases expected to double by 2050. So as the population continue to age dramatically. Okay, so now we going to 2050, and so we expect 2 times from now. So 2 times cases from now. Okay, this growing epidemic demand our attention, understanding, and action as families and communities prepare to support millions of affected individuals with Alzheimer disease. Okay, so next we look at stages of Alzheimer disease. So we have 7 stages are broken down into 4 sessions. So first session is no dementia. We call Risberg stage 1. Okay, so for stage 1, no cognitive decline, no complaint of memory problems, no evidence of cognitive deficits. Okay, for early stage, so we starting from stage 2 and stage 3 for early stage. So stage 2, very mild cognitive decline. So reports of memory problem like misplacing object or forgetting names. Okay, so elderly having Alzheimer disease stage 2 having memory problems. So not evident on issue with words or social situations. So patients still can work and social like before, but a report to memory problem like misplacing object. Okay, for stage 3, under early stage, we call mild cognitive decline. Patient having impaired concentration, difficulty with work tasks, and some denial and anxiety about the deficits. And then next stage, we call middle stage or third stage, but stage 4, 5, and 6. Okay, for stage 4, moderate cognitive decline, trouble remembering personal history. So the patient forget the previous history. So trouble traveling or handling finance. So patient cannot handle the finance. Okay, reduce expression of emotion and withdraw from situation that are challenging. Okay, next mild stage 5, moderately severe cognitive decline. Some assistance needed. So family need to assist some activity of elderly patient. So evidence of short-term memory loss. And then lack of orientation to time, place and date. Patient also may need assistance with choosing what to wear. Okay, so patient starting decline to manage their self-care. And then mild stage 6, severe cognitive decline, lack of awareness of recent activities or surroundings. Activities of daily living may require assistance. Evidence of incontinence and all bowel issue. Patient having sleep disturbance and personality and behavior changes occur, including hallucination, anxiety, agitation, and obsessive behavior. Okay, late stage is stage 7. Very severe cognitive decline, significant personality and behavior changes. Patient loss of speech and ability to hold a conversation. Okay, wait. Patient also difficulty moving, eating, and swallowing, and loss of bowel, bladder and bowel control, and able to do daily activities without assistance. Okay, this one from Alzheimer disease.net 2025. Okay, now we go to pathophysiology of Alzheimer disease. How Alzheimer disease occur. So first, caused by amyloid plaque. Abnormal build-up of amyloid plaque begins destroying brain neuron. Okay, so we can see the Alzheimer disease patient, their brain is destroyed. Abnormal clumps of beta amyloid protein build up between nerve cells. This plaque disrupt communication pathway between neuron. So brain also got the plaque, not our teeth. Brain also can destroy by plaque. Okay, second cause is neurofibrillary tangles. Tangles in Malay we call kusam. Kusam or kabuen. Inside brain cell, a protein called tau. Tau is one of the protein in our brain. So tau is not a good protein, but not healthy of protein. So tau become abnormal and form twist fibers. These tangles cause the structural collapse of our neuron. Sorry. Okay, next. Neuronal degeneration. Okay, over time, brain cells shrink and die, starting in the hippocampus, the area responsible for memory formation. This is why memory loss is often the first symptom. And lastly, loss of acetylcholine, the neurotransmitter responsible for learning and memory decline significantly. But these cases, patient loss of acetylcholine. These causes can develop of Alzheimer disease. Okay, next we look at risk factors. Risk factor can be divided into 9 modifiable and modifiable factors. Okay, non-modifiable factors, this one cannot be changed, but they highlight the need for target screening. This one we should take this important to maybe can prevent the Alzheimer disease. Okay. Non-modifiable risk factor is the strongest risk factor. The prevalence double every 5 years after age 65. So increasing numbers of age can increase the risk of factor Alzheimer disease. So number 2, gender. Women are disproportionately affected, accounting for a higher proportion of cases and death. This one from Zhu et al. 2025. And then other risk factor is family history. Okay. Next, ethnicity. The prevalence of AD is higher in Native American. This one from Rawat et al. 2024. And last, for non-modifiable risk factor is genetic factors. APOE, E4 genetic increases risk. Okay. Okay, next we look at a modifiable risk factor. Okay, this one critical for prevention because this can modify the risk factor. Okay, first, cardiovascular disease. Number 2, hypertension. Number 3, diabetes, obesity, smoking, social isolation, physical inactivity, low educational attainment, poor diet, depression and unmanaged stress, and hearing loss. A major but often overlooked risk factor. So they ask where public health and nursing intervention made the biggest impact. Research suggests that up to 45% of dementia cases could be delayed or prevented through lifestyle modification. This is significant and empowering. So this one we should take note to prevent or delay the Alzheimer disease cases. Okay, now we look at clinical manifestation. Okay, this one clinical manifestation for early stage. Okay, memory loss. Common symptom of early stage: forgetting name or appointment occasionally and remembering them later. And for difficult performing familiar tasks, occasionally forgetting why they came into a room or what were planning to say. And new problem with writing or speaking. Sometimes patient having trouble finding the right words. Okay. Confusion with time and place. Patient will be forgetting the day of the week or where are going. And then for poor or decreased judgment, patient making a questionable or debatable decision from time to time. And then problem with abstract thinking, finding is challenging to balance of checkbook. Ada sign misplacing thing and losing the ability to retrace step. Patient misplacing key or a wallet but being able to retrace step to find it later. For change in mood or behavior, patient occasionally feeling sad or moody. And for trouble understanding visual image and spatial relationship, the visual changes related to cataract. Okay, and then last, withdrawing from social activity, patients sometimes feeling very over or social obligation. Okay, this all for early stage. Next, for middle stage, patient having confusion about time and place, difficulty with routine tasks and mood behavior changes. Patient become agitation and anxiety. And then for late stage, patient having severe memory loss, inability to recognize family members, and loss of ability to perform basic self-care. Okay, for assessment for Alzheimer disease. Okay, as a nurse, we should assess health history. Okay, medical history, family history, social and cultural history, and medication history. Okay, is Alzheimer's genetic? Having a parent, brother or sister with Alzheimer's increases the risk, but not doesn't mean will develop Alzheimer. Okay, for physical examination, we should monitor the vital sign. Okay, also we should inspect overall appearance for hygiene and nutritional status. And then for screening, we perform using standardized tool. Okay, we use Battle Index. Battle Index, a tool for assess activity of daily livings. And then also we assess using MMSE, mini mental state examination. Okay, then Montreal Cognitive Assessment, MOCA. And last, the clot drawing test, CDT. This one all to assess for Alzheimer disease before we diagnose patient as a AD. Okay, this one form of Montreal Cognitive Assessment, MOCA. Okay, this form similar to MMSE, but the MOCA is an objective assessment of orientation, attention, and circulation, recall language, and practice the performance of an action. Okay, this form, the test has drawing, naming, recall, and orientation section. Okay, for naming, the individual is asked to name animals. Example, okay. The MOCA is better at detecting mild cognitive impairment than the MMSE. MOCA score range from 0 to 30, like the MMSE. With a score of more than 26 consider normal, but less than that is abnormal. Okay, MOCA cut-off score can be used to distinguish between the mild 18 to 25 points, moderate 10 to 17 points, and severe less than 10 points. Cognitive impairment. Thought more research is needed regarding this cut-off. Okay, this is example item for MOCA form. Alternative trial making, examiner asks individual to draw a line going from a number to a letter in ascending order. This one example. Okay, naming, we visual constructional skill, naming, memory, attention, sentence repetition, verbal fluency, abstraction, delay recall, and orientation. This one from mantra.com. Okay, for MMSE, or we call mini mental state examination, D is form we use to assess mental patient. Okay, maximum score is 5 and then minimum of a score is 1. Okay, so this all we assess. What is the year, season, date, day of the weeks or month? Where we will now, state, country, town or city, hospital or floor. We ask whether patient remember or not. Okay, the examiner name 3 unrelated objects clearly and slowly, then ask the patient the name all 3 of them. The patient response is used for scoring. The examiner repeats then until patient learn all of them, if possible, number of trials. So, what the number of trials? Okay, and then we ask, I would like you to count backward from 100 by 7. These all example of assessment. Okay, for the clot draw test, okay, we ask patient to draw the clot and abnormal patient cannot complete the clot. This example. And then for normal, patient can complete the clot. So this one indicate the absence of dementia or Alzheimer disease. Okay, next for diagnostic test. So how we diagnose the patient? Okay, depend to the result of diagnostic test. Okay, first brain imaging. Okay, we test CT scan and MRI scan. Okay, so we can see the result for normal adult, normal older adult, low amyloid and tau. Tau, what I mentioned before, one of the protein in our brain. Okay, so for normal adult, older adult, by high amyloid and tau, we can see the result. Okay, a lot of spot of green, and for AD patient, high amyloid and tau, got spot or got spot of red color. Okay, and then for amyloid, this one for normal, low amyloid, and second still normal but high amyloid, and third one high amyloid. This one result for AD patient. Okay. We also assess or test for blood. Example, CBC, chemistry profile, thyroid, function study, folate and B12 level, homocysteine, methylmalonic acid, and vitamin D to support or to diagnose the Alzheimer disease. Okay, and then for treatment for AD, there is no cure for Alzheimer, but pharmaceutical therapy and non-pharmacological therapy can slow progression, manage symptoms, and promote quality of life for the patient. Okay, so what our medical management? Okay, we use pharmaceutical therapy. Okay, we use two group of medication, cholinesterase inhibitors and N-methyldeaspartase receptor antagonist. So for cholinesterase inhibitors, medication like rivastigmine, donepezil, and galantamine. Okay, this one dosage to give to patient. Okay, for N-methyldeaspartase, or we call NMDA, the medication is memantine. We give 7 to 25 milligram daily. This one example, the medication we give to patient. Okay. Non-pharmacological therapy is nursing care. So what our nursing care? To care the patient with AD. Okay, first supporting cognitive function. This is a very important nursing care. Okay, early phase. During early phase, minimal cueing and guidance needed for patient fairly independently for a number of years. Okay, when cognitive ability decline, okay, family member must provide more and more assistance and supervision. A calm, predictable environment help interpret their surrounding and activities of elderly. Okay, for environment stimuli limited, a quiet, pleasant manner of speaking, clear and simple explanation help minimize confusion, disorientation, and give sense of security. Okay, prominently display cloth and calendars may enhance orientation 2 times. So we should display cloth and calendar. Okay, so next, maintain social connection, active participant and regular social interaction, reduce isolation and depression while stimulating cognitive pathway and emotional well-being. Okay, next, promoting physical safety. This is our nursing care. Okay, first to prevent fall and injuries, we remove all obvious hazard and handrails are installed in the home. Okay, and second, we should prepare adequate lighting, especially in halls, stairs, and bathroom. Not light are helpful, particularly if the patient has sun dawning. Okay, but prohibited to the patient is driving. Patient cannot drive. Okay, because dangerous to the patient and others. Okay, smoking only with supervision. If patient smoking, need the supervision. Okay, avoid restraint. Okay, we should avoid because restraint can cause patient increase in agitation. Okay, if patient at outside, we must supervise. Okay, we encourage wear an identification bracelet to the patient. Okay, third, our nursing care is promoting independent in self-care activities. Okay, simplify daily activities, organizing them into short, achievable steps. Okay, only short activities. Okay, for occupational therapy, we suggest frequently can suggest way to simplify tasks of recommended adaptive equipment. So how to use the assistive equipment. Okay, for direct supervision, sometimes necessary, but however, maintaining personal dignity and autonomy is important. Okay, so direct supervision only for some time. Okay, make choice. Okay, this one we also encourage patient make choice when appropriate. Okay, also we encourage patient to participate in self-care activity as much as possible. So this one all to promote self-care activities. Okay, next, reducing anxiety and agitation. How to reduce? First, remain calm and unhurried. To avoid screaming, crying, and becoming abusive. Okay, we also postpone the activities. Okay, because forcing the patient to proceed with activity only increase the agitation. And then we structuring activity to measure, such as moving to a familiar environment, listening to music, stroking, rocking, and distraction may quiet the patient. Okay, number five, improving communication. Why? Because to promote the patient interpretation of message. So we remain and hurry and reduce noise. Okay, for use of clear, easy to understand center, patient is frequently forget the meaning of words or having difficulty organizing and expressing thoughts. Okay, for tactical stimuli, suggest we can heart or hand pads are usually interpreted as sign of affection, concern, and security to the patient. Okay, next, providing for socialization and intimacy need. Okay, we encourage socialization with friends. It can be comforting. Visits, letters, and phone call are encouraged. Okay, for recreation is important. Hobbies and activities such as walking, exercising, and socializing can improve quality of life for the patient. Okay, it did not eliminate intimacy. Patient and their spouse may continue enjoy sexual activity. Okay, for promoting adequate nutrition, for mealtime can be a pleasant social occasion for the patient and family. Patient prefer familiar foods that look appetizing and taste good. So, family should prepare the food appetizing and taste good. Okay, to avoid playing with food, we should serve one dish at one time and put it cuts small piece to prevent choking. Okay, for hot food and beverage, we should serve one and the temperature of the food should be checked to prevent burns before give to the or before serve to the patient. Okay, next, promoting balance, activity, and rest. For sleep disturbances, if sleep is interrupted, patient cannot fall asleep. Music and warm milk help the patient relax. During the day, patients should be encouraged to participate in exercise because a pattern of activity and rest enhance nighttime sleep. But for daytime sleeping, periods of daytime sleeping are disencouraged. So avoid to sleep at the daytime. Okay, lastly, supporting home and community based international burdens on the family. We should provide education and early discussion of transition of care. Okay, for non-pharmacology approach, we educate and connect caregivers about pharmacology approach to care and need for respite for the caregiver. And establish a
Patiin dulu itu, belum dipatiin.
Iya, siapa tahu kita mau makan begini.
Oh,
Enggak
usah.
establish a relationship
Tidak pakai jilbab.
establish a relationship to provide a personal empathic approach on the end of life issue. Okay. Can Alzheimer be prevented? The current science, yes, 45% cases potentially preventable. Nearly half of dementia cases may be delayed or prevented by addressing modifiable risk factors. This one from Lancet 2024. Okay, 0% guarantee prevention. No method currently exists to completely prevent Alzheimer's, but risk reduction is possible. 12 plus modifiable risk factor, multiple lifestyle and health factors can be controlled to reduce overall dementia risk. So promising intervention include aggressive blood pressure control, regular physical activity, cognitive training program, and managing conditions like diabetes, hearing loss, and high cholesterol. So all these to prevent of Alzheimer disease. Okay, key lifestyle strategies to reduce risk. Okay, first, stay physically active. Engage in at least 150 minutes per week of moderate exercise to improve brain blood flow, reduce inflammation, and support neural health. We encourage eat brain healthy food, follow a Mediterranean style diet rich in fruits, vegetables, whole grains, fish, nut, and olive oil to nourish cognitive function. The use probiotic in the elderly has been shown to improve the anti-inflammatory properties of the gut, cash, blood, and Smith. So we can encourage elderly to use probiotic. Okay, keep mentally engaged. Challenge your brain with puzzle, reading, learning new language or skill, and creative activity to build cognitive reserve. So we should maintain social connection, regular social interaction, reduce isolation and depression while stimulating cognitive pathway and emotional well-being. Okay, managing medical risk factor, control blood pressure, manage diabetes, address hearing loss, and eliminate harmful habits. Okay, my conclusion, hope through prevention and compassionate care. The Alzheimer disease, no cure but real hope. Why no cure exists yet? Lifestyle modification and medical management can meaningfully delay onset and improve quality of life for years. And for early action method, early intervention, info, caregiving, and community support empower families to face challenges with greater confidence and resilience. Together, we are stronger. By combining scientific knowledge, lifestyle changes, compassionate care, and community support, we can face Alzheimer's in elderly people with empathy and action. Okay, this one, my suggestion, research and global perspective. Okay, main research kept in AD. We can conduct the research related to early biomarkers, culturally adapted screening tool, non-pharmacological intervention, and community-based care models. Okay, this is my reference. Okay, that's all. Thank you. Any question?
Thank you very much, Madam Sadiah Binti Zakaria, for your insightful presentation. I believe that all students, lecturers as well, could benefit much from your presentation. And because your presentations is very interesting, I believe that most students, most audience have their questions, issues that they need to understand deeper. So this is a good opportunity for the Q&A sessions. So before we move further for the Q&A sessions, I would like to call out for participants. Please, participants from the Diploma-3 of Nursing Tanjungkarang, please provide Madam Sadiah Binti Zakaria with applause. Your reaction, please provide applause with reaction. Okay, thank you. Okay, I would like to see more applause for all the participants, for all the audience. Okay, now I would like to see more applause from more students. Okay, so all the audience are still there, madam, for your presentations. Okay, so thank you for the applause and for all reactions. Okay, I see many loves in the air. Okay. Yes, okay, so.
And claps. And
Yes. Now we will now move for discussion and Q&A sessions. So I invite all the audience to provide with the answer. Please, I welcome for all of you. If you have any question, please raise your hands and I will ask the committee to unmute the participants, and then you need to mention your name and what study program you are from, and then provide your question. Okay, I see this is Dinda from STR Keperawatan, from Diploma 4 of Nursing. Okay, please, you may unmute your speaker and your question, please.
Okay, thank you so much, and good afternoon, Madam Zaida.
Okay, good afternoon. Apa
Allow
cangnya?
me to introduce myself. My name is Dina Cahyani Fitri, Bachelor of Applied Nursing from Poltekkes Tanjungkarang. I would like to ask a question to Madam Zaida with your permission. In many Asian cultures, cognitive decline is often stigmatized or considered just a part of aging. How can nurses help reduce this stigma so that patients receive better social support? Thank you.
Okay. How to reduce the stigma, right?
Yes.
Yeah, how to reduce the
Correct.
stigma
Thank
among
you for
community,
your
right?
questions.
Okay.
Okay. Do you want to answer the questions, or we will collect? Maybe there's another question. Okay. Okay. We have one question, and I welcome another question from all participants. You can ask from the risk factor, or maybe the strategies to the identification in the early detections, maybe, or even from the research gap that has been presented by Madam Sadiah, for maybe your future research. Okay, is there any more questions? Okay, maybe yes, it will be appropriate if you provide the answer first time, Madam Sadiah. You may answer the first questions. I see another hand raised, but it's okay for you to answer the first questions. From Dina Cahyani, asking how to reduce stigma for Asians elderly so that they may receive more proper treatment. Time is yours, madam. Hello, am I still audible?
Okay, I answer now or?
Yes, madam.
Okay.
You may.
Okay, how we can reduce the stigma among the communities. So my suggestion, okay, so how to reduce the stigma? We should educate the community about the aging process, and everyone will experience this symptom. So we should educate early our community from young until adult. So communicate early what is the aging process. So because when we look at the statistic or prevalence, about 1 million patient having the dementia disease. So maybe we also can risk about the Alzheimer disease. So we should educate people because everyone chance to get the Alzheimer disease. So that can reduce the stigma about the stigma from the public. We also can do the campaign, seminar or healthcare promotion.
Okay. Participants with, okay, it's echoing. Okay, I'll give it back to you again, madam.
Okay, my answer or need further explanation?
Yes, please, madam. Please continue.
Continue next. Okay, we promote person-centered care. So mean person-centered care, we combine medical and nursing care to the patient.
Okay.
Okay. When healthcare professional and caregiver focus on the individual preference, strength, and life history, stigma is reduced because the patient is viewed as an active participant rather than as a passive or deteriorated individual. Okay.
So those are things that we need to do to lessen the stigma from the community, right, madam? So yeah, we will. I believe that we will satisfy the participants for their questions. Okay, in the chat box we have other two questions, but I would like to invite Mr. Imam. You can ask directly to Madam Sadiah. Yes, please. You may ask directly to Madam Sadiah. Mr. Imam, time is yours.
Thank you, Mr. Fajar. Madam. Madam, I will ask the question. What are the most common challenges caregiver face in caring for older adults with Alzheimer?
Sorry, Imam Budi, what?
Imam Budi, okay.
Would you like to repeat your questions, Mr.
Please repeat your question.
Okay, thank you. What are the most common challenges caregivers face in caring for older adults with Alzheimer's?
Caring our.
Okay. The most challenging while giving providing care for elderly with Alzheimer, right? Okay. For the next questions, we will have Nadifa Aptam Meilasilia from Diplomatry of Nursing, Kota Bumi. I invite Nadifa. You can ask directly to Madam Sadiah. Nadifa, please turn on your camera and you may ask directly to Madam Sadiah. Are you still there? You can unmute your speaker. Okay, Maybe I'll read the question from the chat box, madam. Okay, the question from Nadifa is the healthcare system adequately prepared to manage the increasing number of elderly people with Alzheimer's, especially in low resources setting? Okay, that's a question from Nadifa. So we have two questions. The first question from Imam asking about the most challenging things while providing care for elderly with Alzheimer's. And the second question from Nadifa asking, Nadifa, asking whether healthcare system is adequately prepared to manage the increasing number of elderly with Alzheimer's, especially in low resources settings.
Manage Alzheimer.
For all participants, if you have another question, you may write in the chat box or you can raise your hands further. Okay, now I'll give the opportunity for Madam Sadiah Binti Zakaria to answer the two questions. Time is yours, Madam.
Okay, I can answer.
Yes, Madam, please.
Okay, from Budi, his question: what a most common challenge for caring our older adult with Alzheimer, right?
It's correct, Madam.
Okay. Okay, the elderly adult having functional dependence and loss of daily activity skill. So what we should do? What the most common? Okay. Okay, first we should assess ADL patient. Okay, and help patient to do the activity of daily living like bathing, dressing, tailoring and feeding. Because the increasing dependent place a heavy burden on caregiver and increase the need for long-term care service. Okay, other our challenges is behavioral and psychological symptom of dementia. Up to 90% of people with Alzheimer experience BPSD common symptom, agitation, irritability and aggressive, anxiety and depression symptom, empathy or withdrawal. So what we should do? We can follow the how to reduce the agitation. Okay, first we have patient to prepare environment calm and unhurried. Also, we encourage patient active participate in social care. Also, we should pleasant manner of speaking, clear and simple explanation to the patient. Okay, answer the question.
Yes, madam. I believe it satisfies your answer satisfies the questioner that actually most things covering in Alzheimer disease are challenging, right, madam?
Very
Because
challenging.
yes, because the elderly are very dependable, very dependent with the carer, right, madam? So all things with Alzheimer disease are challenging. Thank you very much for the answers, and we now move to the second question from Nadifa. Nadifa asking actually, are our healthcare services institutions are actually ready to to provide care for the increasing number, the paramount burden of the Alzheimer disease that we are facing right now, especially facilities with low resources, madam. And yes, kindly, I invite you to, time is yours for you to answer the questions, madam, for the second question. Or maybe I can move. There is one more participant raising their hands for questions. I see Gabriel Luis. Please, your questions, Gabriel Luis.
Thank you for Mr. Fajar because okay, let me introduce myself. My name is Gabriel Valentino, student majoring of nursing diploma 3, Poltekkes Tanjungkarang. I want to ask question for Miss Zaida.
Yes.
Does Alzheimer disease only occur in older adults, or can young people also develop it? And if young people can get Alzheimer, what can we do to reduce the risk?
Okay.
Sorry, can you repeat
Okay.
your
He has two questions actually, madam. The first question from Gabriel is Alzheimer disease only affecting in elderly or youth can have this Alzheimer as well? And the second is if the youth may have this Alzheimer disease, what should the youth do to prevent the disease?
what should do to prevent disease, right?
Yes, that's right. Okay. Yes. Do you want to answer directly, madam, for the last two questions? Question from Nadifa and Gabriel.
Nadifa, right?
Yes, correct.
Okay, so for Nadifa, the question, what healthcare prepared to manage Alzheimer disease people with limited research, right?
Correct, madam.
Okay. Okay, management of Alzheimer disease in our country, in Malaysia, current preparedness and ongoing challenges. Okay, because national demographic pressure, Malaysia is becoming an aged nation by 2030. So now we got we have the policy how to manage patient with dementia, but not Alzheimer. So because dementia more cases than Alzheimer, because Alzheimer part of the dementia. So we just only got the policy for dementia, but we prepared how to manage patient with Alzheimer, because Malaysia is becoming in age nation by 2030. So many years more, about 5 years more to become Malaysia become aging aging nation. Okay. Second.
Yes, correct, madam.
Okay. For second question, is ADR affecting our family? Right.
Yes, whether Alzheimer disease may affect only in elderly or it may affect youth as well, madam.
Affect our family. Okay, so based on my presentation, Alzheimer disease okay. Not heredity, but someone has history of a family history of AD, risk to get the Alzheimer. Sorry.
So family history poses younger generation that they might develop the disease. Right, madam?
Okay. What I mentioned before, if some we have a family having Alzheimer disease, the family maybe risk, but doesn't mean that we develop of Alzheimer. Okay. Okay, answer the question. And second, what should do the prevent? So the Alzheimer, actually Alzheimer, sorry, wait. Okay, sorry, I won't share my slide before.
Yes, please, madam.
Okay, Alzheimer is no cure for Alzheimer, but pharmaceutical and non-pharmaceutical therapy can slow the progression, manage symptoms, and promote quality of life. Means Alzheimer cannot prevented, but we also we just to reduce the symptom and slow the symptom with pharmacological and non-pharmacological therapy. So cannot, but to slow the symptom. Okay. Okay, answer the question. Sorry.
Yes, madam. Yes,
So,
clarify. Yes. Okay. Okay. Let's see. Do we have any other questions from participants? We all can see that the sessions of our lecturer today is very interesting. We can see many questions from all the participants. Comprises for the risk factor, the preventions, the identifications, even healthcare services readiness to cover care for the AD patients. So I believe that it inspired all the participants our lecture today. So, okay. We still have another 10 minutes if so we can welcome one more questions for participants if you still have anything that you need to clarify from our keynote speaker here today. Okay, maybe the community can help me to identify is there any other raised hand? Oh, okay. Okay. I believe that all participants are very inspired with your presentation today. So, okay, if we have no more questions, okay, I would like to offer my gratitude for all participants, and let's provide more applause for our inspiring keynote speaker, Madam Sadiah Binti Zakaria. Okay, please, yes, provide applauses because this is very interesting presentations in our afternoon time. Because at this time, usually, madam, most our students got very sleepy because it's time. Yes, after lunch, usually we get sleepy. But we can see that students' engagement or participants' engagement in this lecture is very satisfying. Many questions from all the participants. Thank you very much for the reactions for all the participants. And well, thank you very much for all your enthusiasm. And due to the time limitation, we will now proceed to the next sessions that with this, we have reached at the end of today's expert lecture on Alzheimer's disease. And on behalf of the organizing committee, I would like to express our deepest appreciations for our distinguished keynote speaker for your valuable knowledge and insights that you shared today. For all lecturers, researchers, practitioners, and students from nursing department of Poltekkes Kemenkes Tanjungkarang and everyone that has contributed for this expert lecture. And now I would like to offer my gratitude and this concludes our expert lecture, and now I'll give this opportunity for the Master of Ceremony.
Okay, thank you.
Thank you very much, Madam, and all
Thank
for
you
the participants.
all participants to give
Okay.
attention to my presentation, also to committee, organizing committee to invite me. Thank you.
Thank you, Madam.
Okay, thank you for Mr. Fajar and Madam Zaidah Binti Zakaria. Once again, let us give a warm round of applause to both our speaker and moderator. Ladies and gentlemen, before we officially close today's expert lecture, it is our honor to present certificates of appreciation to our distinguished speaker and moderator as a token of our gratitude. Now, we would like to invite the Coordinator of Academic Development to present the certificate of appreciation to our esteemed speaker and moderator. To Ibu Dr. Anggun Rusyantia, MEP, the time is yours.
Okay, thank you so much, Miss Shifa. Can you hear my voice clearly?
I can.
Yes.
Okay,
Yes.
thank you so much. Okay, Assalamualaikum, Madam Sadiah Binti Zakaria. Assalamualaikum. Okay. Okay, on behalf of the organizing committee, we are grateful to everyone who contributed to making this event meaningful. And first, I would like to present this certificate to our guest speaker, Madam Sadiah Binti Zakaria. Thank you, Madam, for taking the time to be with us and sharing such valuable insights. And your presentation has given us a new perspectives. Yeah. And
Welcome, Dr. Anggun
yeah, we
Rusyantia
hope
for invite me.
okay, our pleasure, Madam Sadiah, and we hope we can meet in person someday, yeah, maybe in Kuala Lumpur or in Lampung, yeah, Madam. Okay. Next, I would like to present a certificate to our moderator, Bapak Fajar Desma Wahyudi. Thank you, Mr. Fajar, for guiding the discussion smoothly and helping the session stay focused and engaging. Thank you so much. And finally, I would like to present the certificate for our Master of Ceremony, Miss Shifa. Thank you for leading the program with great energy and keep becoming an inspiring student. Once again, we truly appreciate your support and contribution to our event, and thank you so much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Atuh.
Now hand the program
Thank you
back to our
very
MC.
much.
Thank you.
Salam to Upin Ipin.
Yeah.
For Ipin.
Thank you, Ibu.
Thank you very much, Madam Sadiah Binti Zakaria. Thank you, Sifa.
Thank you, Sifa. You are very good.
Yes.
Yeah, good, Shifa.
Thank you to Ibu Anggun Rusyantia. Once again, let us give a warm round of applause to both our speaker and moderator. On behalf of the organizing team, I would like to express our deepest gratitude to all who participated in making this event a success. Your time, enthusiasm, and support have been invaluable. Thank you for joining us, and we hope today's session has been insightful and inspiring. We look forward to seeing you at our future events. Have a wonderful day ahead and see you next time. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Madam.
Mr. Fajar. Thank you, Madam
Thank
Zaidah.
you.
Thank you, Sifa.
See you next time.
Annie.
Hello, Bu Heni. How are you? Bu Heni? Already left ya meeting. Okay, thank you so much. We end the meeting ya.